Dear moderator, you can start your talk just after 5 seconds.
Dear participants, Assalamu alaikum and good evening. Welcome you all in 70th lecture session organized by ECG study group. Today our topic is common mistakes in the diagnosis of ACS or acute coronary syndrome, and the lecture will be delivered by respected Professor Abdul Kader Akanda sir. But before start of the lecture, I'd like to request Professor Abdul Jamil sir to say some words regarding Abdul Kader Akanda sir, and also request him to introduce Atahar Ali sir to have basic lectures on ST segment. Abdul Jamil sir.
They talk about Abdul Kader Akanda. Sir?
Yes sir. Akanda sir সম্পর্কে আপনি একটু বলবেন প্লিজ।
ওই আকন্দ কই?
পরে আসবে, বাট আমরা ওনার ইন্ট্রোডাকশনটা অবশ্যই প্রয়োজন।
Thank you very much, Tushar, for allowing me to say something about Professor Abdul Kader Akanda. He's a very honest, sincere, and dedicated person in the field of cardiology. He's a good interventional cardiologist, has long experience, and is a very good teacher also.
Assalamualaikum.
ওয়ালাইকুম কি অবস্থা তোমার?
এই বের হলাম, বাসায় যে জয়েন করব।
ঠিক আছে যাও। আমি শুরু করছি।
হ্যাঁ শুরু করে দাও।
And Abdul Kader, he is known to me for a long time. We are contemporary from different medical college. We joined in medical college at the same time. Nothing to say more about him. He is an excellent man, and I honor him a lot. Thank you very much. And Professor Atahar Ali, everybody knows about him. Nothing to be mentioned again. My deep respect from my heart to Professor Atahar Ali. Please start.
Thank you, dear Abdul Jamil, for introducing me and Professor Abdul Kader Akanda. Actually, today's session is scheduled for Professor Abdul Kader Akanda. Very important and interesting topics, but he is on the way because of traffic jam. He has got some delay, and by this time, I want to say something about the STD segment, that is physiology of the STD segment. Can you see my slide, Jamil?
No sir, not visible yet.
It's coming, not yet seen. We can see blank white screen and your mouse cursor.
Still not visible, na?
No.
Not yet, sir.
Stop sharing. So can you see now?
না এখনো শেয়ারিং হচ্ছে না, হ্যাঁ স্ক্রিন শেয়ারটা করেন। হ্যাঁ এখন দেখা যাচ্ছে।
দেখা যায় জামিল?
হ্যাঁ এখন দেখা যাচ্ছে।
জি এখন দেখা
হ্যাঁ
যাচ্ছে।
এখন
So, dear participants, good evening, and particularly respectable Dr. Azizul Haq Bhai, Dr. Abdullah Al Jamil, Kanis Fatima, Ashif Jaman Tushar. Welcome to everybody and dear participants. Today's session is particularly designed for Professor Abdul Kader Akanda. He will talk on some common mistakes, difficulties in diagnosis of acute coronary syndrome and some mistakes in acute coronary syndrome. And regarding this, before his coming, I want to talk something about ST segment, as because ST segment is related with the acute coronary syndrome. So this is the basic and introductory talk about the ST segment. So dear participants, we know about the basics of the ECG and definition of the ST segments in ECG. ST segment in ECG is the part between the J point and the beginning of the T wave. J point is the junction between the end of the S wave and begin, that is from the end of the S wave. This is the junction of the, there is a junction between the end of the S wave and beginning of the ST segment. This is the J point. And this is the beginning of the T wave. This portion is called the ST segment. This segment is very much important. This small area is very much important in ECG and interpretation of the acute coronary syndrome related ECGs, because in acute coronary syndrome ischemia infection, this is the part which is affected most of the times, and diagnosis of the acute coronary syndrome, infection, unstable, everything related to the ST segment. So this is the ST segment, the area between the J point and the beginning of the T wave. But the junction, what we see in the slide and in the ECG, is not so clear all that time. Sometimes it is difficult to identify the end of the S wave and beginning of the T wave. And similarly, it is difficult to define the junction between the end of the ST segment and beginning of the T wave. But by definition, this is the area. So from ECG, this is the
Assalamualaikum.
part. Wadud bhai.
Assalamualaikum.
Assalamualaikum, Wadud bhai. So before Professor Abdul Kader Akanda, I want to talk something about the ST segment. So this is the definition of the ST segment in ECG. And electrophysiologically, this is the part of the ECG in cardiac cycle that lies between the depolarization and the repolarization. T wave represents the repolarization, the R wave represents the depolarization, and this is the part between the depolarization and repolarization. This is actually beginning of the repolarization when the ventricle in the contractile state. But during this time, the heart remains the contractile state, no further movement of the electrons happens. So this is the ST segment in ECG. And if we correlate the ECG with the action potential, the ST segment correlate with the phase 2 of the action potential. Phase 2, we know this is the play 2 phase of the action potential. During this time, the heart remains in the contractile state. Contractile in the isometric contraction phase. All the ventricular muscles are in the contractile phase. At this time, during this brief period of time, the ventricle has started repolarization, but still in the contractile phase. There is no further ionic movement. So this is the region, this is the isoelectric, as because there is no changes of the membrane potential during this time. So this segment remains the isoelectric. Why this is isoelectric? Is because during this time, all the contractile cells of the ventricle in the contractile phase, there is no further ionic movement. There is no further changes of the membrane potential. So the ST segment remains in the isoelectric phase. So this is the ST segment, and this is the reason why the ST segment in the isoelectric phase. But in ischemia, during the ischemia, that is when there will be acute coronary syndrome or something changes like the ischemia, the permeability, because of the ischemia, the permeability of the contractile cells are changed. So there will be changes of the membrane potential, changes of the threshold potential, and as because there will be changes the potential, depending on the polarity of the potential, the ST segment will deviate either upwards or downwards. So this is the region, this is the part what was isoelectric in normal state become unstable during the acute ischemia. So this is the ST segment, and this is the region why the ST segment becomes either goes upward or downwards during acute ischemia or acute coronary syndrome. So this is the answer. And we know during the acute ischemia or the ischemic heart disease, or when there will be some occlusions of the coronary arteries, there will be three areas. This is the very classic picture in the textbook. This is the three areas, that is the three zones. This is the infarct area, this is the peri-infarct area, and this is the peripheral area. And all the cells, the cells here is the necrosed, that is infarcted. This is the injured cell, and these are the ischemic cells. So ischemia, injury, and infarction, that is necrosed. There will be three kinds of the cell at the site of the occlusion, and ECG records electrical activity of all these areas. The necrosed area, this is electrically inert, so produce the Q wave. This is the injured area, so this is the electrically unstable, and depending on the polarity of the electricity, there will be changes in the ST segment. And the white, this is the ischemic area that will reflected by the T wave polarity. So these are the classic findings of the STT segments during the acute coronary syndrome and ischemia, that is the infarction, ischemia, and injury. Not all the three areas or three zones present at the same time. There may not be the infarct area, only the two areas, may not be the ischemic area, only the injured area. So depending on the presence or absence of all the three areas, the ECG will record the electrical activity. And from this ECG, we can predict what is happening inside the heart. So this is very much important for understanding the physiology of the ST segment. And during the ischemic events, the ST segment either may go up or may go down. That is elevation or depression. What is the physiology? Why the ST segment goes up and why the ST segment goes down? This is the normal physiology, and the conception is that depending on the location of the injury, either it is the transmural, or it is the epicardial, or in the endocardial, and position of the electrode. This is the position of the electrode. As for example, this is the position of the electrode just overlying the injured area, and this injured area is subepicardial. We know when there will be injury, this area will become negative. This area is become negative relative to the normal area. The normal area is positive, this area is negative. So the electricity will go from normal to the abnormal area, from positive to the negative. So the vector of the electricity movement, that is the current of injury, the vector of the current of injury from normal to injured area, that is from epicardial, that is the endocardial to epicardial, where the electrode is present, that is the force is going toward the electrode source. So there will be ST segment elevation. So in case of the epicardial injury, epicardial ischemia, the electricity will come from the subendocardial normal area to the ischemic area, that is epicardial ischemic area, so toward the electrodes, and so there will be elevation of the ST segment. This is the mechanism why the ST segment is elevated in case of the epicardial or in the transmural myocardial infarction or like this. But when there will be subendocardial injury, ischemia, this area is now negative and this area is now positive. Here is the location of the electrode. Electrode is overlying this area and the force is going from this area to this area. So the vector or polarity of electricity is going away from the electrodes towards the cavity, towards the negative part, toward the injured area, from positive to the negative side. That is going away from the electrode. So there will be ST depression. So this is the mechanism of ST segment depression in subendocardial ischemia and ST segment elevation in case of epicardial ischemia or injury or transmittal myocardial infarction. So this is the basic physiology why the ST segment goes up or goes down in acute coronary syndrome. The ST segment deviation, what I have told, the ST segment deviation either goes up, that is ST segment elevation, or goes down, ST segment depression. Actually, the ST segment is isoelectric in comparison to the either PR segment or TP segment. I will show it later on in relation to this. That is, we have compared, this is the scale, that is the PR segment or that is the TP segment. This is the scale, this is the baseline, this is the isoelectric line. And from this line, how much the ST segment elevated? And in comparison with the PR segment, the elevation or depression of the ST segment should be measured at the J point. This is the J point. But if we compare with the TP segment, we have to measure the ST segment about 60 or 80 milliseconds after the J point. This is the J point. This is 40 milliseconds. This is 80 milliseconds. As per example here, if we compare with this part, we have to measure here. We have to measure 40, 80. We have to measure here. We have to compare this area, that is the TP segment. But if we compare with the PR segment, then we can just measure at the. So these are the academic, but for practical purpose, this is not so important as because this is that is the point-to-point measurement is not. But academically, if we compare with the PR segment, just measure at the J point. If we compare with the TP segment, just measure at J60 or J80 millisecond from the starting of the J point. So this is the way how to measure the ST segment deviation from the baseline. And this is one of the example. As for example, from the CC we can see this is the PR segment. This is the PR segment. This is the T, and this is the TP segment. This is the P, and this is the TP segment. So this is the isoelectric line. This is the baseline, and ST segment deviation should be compared with this line or with this line. With this line at the J point, that is at this point, and with this line at 40 or 60 milliseconds at this point. So this is how we measure the ST segment deviation from this point. If you see, this is the V2, the ST segment, that is J point is elevated. If we compare with the PR segment, that is the ST segment elevated about 2 millimeter, that is 2 millivolt. The 2 millivolt ST segment is elevated in V2. So this is the way how we calculate the ST segment, and the ST segment deviation either isoelectric normally, irrespective of conditions. The ST segment either will be isoelectric as in physiology, or in case of injury, there will be deviation either above or down, and this is how we measure the ST segment deviation from the baseline. The baseline will be either PR segment or TP segment. TP segment. This is the ending of the T, and this is beginning of the P. This is the isoelectric line. So we have to compare the ST segment deviation comparing this either of these two parts. But when there will be tachycardia, it is difficult to define the ST segment deviation. This is very much difficult to define the ST segment deviation. There is some assumption, but clearly it is difficult to define the ST segment deviation. As because I have already told, the beginning, that is the J point, and the beginning of the T wave are not always very sharp. In many conditions, the area is very much blurred, very much diffuse. Pinpoint identification of the J point and the beginning of the T wave is very difficult. As for example, these kinds of the during tachycardia, it is difficult to, we just see there is T wave inversion and hopefully the ST segment is also downward, but it is difficult to define very clearly. This is the ST segment. This is the ST segment. Yes, there is some assumption, there is some changes, but it is very much difficult to define. This may be the J point. This is the beginning of the T wave. This only small area is the J point. So this is very much difficult to define the real deviation of the ST segment during the tachycardia. So also, this may happen during the acute coronary syndrome. This is one of the ECG of our patient during the acute coronary syndrome. Wide QRS complex. Definitely we see some changes in the ST segment. Definitely we see, but it is very much difficult. This is what? This is what? So there may be some debate. This is what? What is this? Is QRS complex or ST segment or something else? So what is the message is that? This is the ST segment, I think. So what is the message? That is during the ventricular tachycardia or acute coronary syndrome in wide QRS complex or bundle branch block, there is very much difficult to define the exact deviation of the QRS complex. We can give some prediction, some assumption, and correlation with the clinical context, but anatomically, academically depend to the ST segment in such situations. So this is one of the example. This is another example you see.
Sir,
This,
if you don't mind, during exam, if students are being asked this ECG, should they comment on ST segment?
yes, they can comment, but this is the limitation. This is not hard and fast that they have to dogmatic about the comment. They can say, yes, this is the assumption, but this is the limitation of the ECG. That is the during tachycardia or some clinical session. I'll show in later of the secondary senses. That is difficult to define. Yes, for example, you can see clearly. You can see clearly. This is the J point. You can see this is the J point. This is the beginning of the T wave. The ST segment is isolated. There is no doubt. You can see this is the ST segment isolated. The ST segment isolated. T wave is inverted. So this is how you can see. This is the J point. Clearly, this is the J point, and this is the beginning of the T wave. So this is the ST segment. So there is some areas when you can see clearly define the ST segment, anatomy of the ST segment, physiology of the, but there is some limitation. Particularly, there is some secondary changes. As for example, tachycardia and other conditions I will show you later on. So there will be some limitation. This is not, there is nothing to be dogmatic. That is this area, that is the ST segment is hugely dilated like this, that is elevated. So this is the condition when we can see clearly, and this is the condition when we is define the ST segment very clearly. So these are the limitation, and ST segment changes sometimes may be primary changes or secondary changes. When the changes are because of the repolarization, as because ST segment is a part of the repolarization. So when the changes is because of the repolarization abnormality, this is the primary changes. And when the changes is because of the depolarization, it is the secondary changes. This is one of the examples of the hypokalemia, that is the QT segment is prolonged. The ST segment is deviated downwards. QT is prolonged, and this is secondary to the hypokalemia. So the ST segment, this is the J point, and this is the very difficult to define clearly the ending of the T wave. So this is the ending of the T wave, and maybe this is the beginning of the T wave. So the ST segment is prolonged, as because we know the QT segment is prolonged because the ST segment is prolonged. That is the two components of the QT, ST and the T wave. Either widening of this, either component gives rise to the prolonged QT segment. So here the QT segment is prolonged because of the lengthening of the ST segment, and this lengthening is because of the changes of the ST segment, and ST segment goes downward. So this shows, I am just focusing that these changes is because of the repolarization changes, and this kind of the change is called the primary STT changes. Primary STT changes. The depolarization is okay. You see the R wave. So depolarization is okay, but repolarization is abnormal. This is the depolarization is okay. Depolarization okay, but the repolarization is abnormal. You see, the ST segment is abnormal, T wave is abnormal. So the repolarization is abnormal. So when the changes is because of the changes in the repolarization, it is the primary changes. And when like this, the changes here you see, there is also changes of the ST segment. And this is the short PR. This is the WPW. This is the pre-excitation. That is the pre-excitation means some changes in the depolarization. That is ventricle is pre-excited. Ventricle is depolarized from the two ways, from the accessory path and the normal contraction system. So this is the depolarization abnormality. You see, there is widening of the QRS corner. So the depolarization is not normal. So these ST segment changes is because of the changes of the depolarization. When the ST segment changes happens because of the changes of the depolarization, this is the secondary STT changes. And this is the primary STT changes. And this is another example. Here also see the ST7, that is J point, that is the nose at the J point, and the J point is elevated with concavity upwards. This is one of the example of the early repolarization. Early repolarization, the very name denotes this is the early repolarization, that is problem in the repolarization. So the STT changes is because of the changes in the repolarization. As because the changes is localized, the depolarization is okay, the repolarization is abnormal. So this is the primary changes. So just this is the academic interest, that is you can think about the STT changes is either primary or secondary. This is only because of the academic. And again, the ST deviation either may be ischemic or non-ischemic. Tushar, just let me know when Professor Abdul Kader Akanda arrives. Just let me know. When Professor Abdul Kader
Akanda joined. Akanda sir has joined, but not as a panelist. I'm requesting Mr. Kamrul to make Akanda sir as panelist. Then we can shift to that lecture room.
Right. When Professor Abdul Kader Akanda joining is finished, just let me know. So the ST7 changes may be either ischemic or non-ischemic. This is the classic and the common conception is that in case of the ischemic, the ST7 deviation, when it goes upwards, the convex morphology is specific for the ischemic changes, and concavity upwards is the non-ischemic changes. So this is the common conception. This is one of the example where the ST segment is elevated, concavity upwards. Clearly you can see lead 1, lead 2, diffuse in all the leads. ST segment goes upwards with the concavity upwards. The depolarization is okay. The changes in the repolarization. So this is the primary changes, and the ST segment going upwards, and many of the leads. So this is one of the example, and maybe due to the pericarditis. So this is the pericarditis, and you can see the changes in the pericarditis. So not only it is the deviation going upwards and deviation. When there will be going upwards, there will be some classic types of the ST segment morphology. ST segment morphology, that is, it may be convex like this. It may be straight from the J point. This is not concave, and this is not concave as because this is the J point, and the ST7 is above and goes straight. Above and goes straight. This is the straight type ST7 elevation. This is the horizontal type ST7 elevation, and this is the tombstone type of the ST elevation. This is classically pictured in this book. There's a Goldberger's book circuit. So you can see this picture in that book. So this is the shape of the ST7 in acute coronary syndrome or acute myocardial infarction, different kind. But the shape is not so important because the shape is very much little role for defining the various kinds of the pathology of the. This shape is just for the academic interest. Different kinds of the shape may happen. This is one of the example, classic example, ST segment elevation, tombstone type. You see this type. What we see, hyperacute phase, very much classic for the hyperacute phase. So this is the tombstone type acute ST segment elevation, tombstone type, very much unstable. The depolarization is also very much, voltage of the depolarization is very much reduced. Maximum voltage goes to the repolarization, tombstone type. This is another example. This is also looks like the tombstone type. You see, tombstone type ST segment elevation, and simultaneously also there is ST7 depression, and because of the reciprocal changes. So this is another example of the different kinds of. This is another interesting example, or you can see the ST7 elevation. This is the inferior lead ST7 elevation. Also, you can see another type of ST7 elevation like this. Another type of the ST7 elevation, either because of the repolarization or because of the ST segment elevation, real ST segment elevation. But maybe this patient has got already the early repolation, as because the J point is elevated, there is some notching and there is some ST segment elevation in the inferior leads. So this is one of the example where I can see both types of the ST segment elevation. So there is some limits of the ST segment elevation. Limit of the ST segment elevation, as for example, in case of the main, in V1 and V2, up to 2 mm is acceptable, but in others list, not more than 1 mm. And in case of women, 1.5 mm V1 and V3, and not more than 1 mm other leads. And there is Minnesota code regarding the ST segment limits. Minnesota code. What I have told already, this is the limits of the ST segment deviation, either going up or down. This is the limit, 2 mm, 1.5 mm, or 1 mm. And that has been nicely described in Minnesota code about the limits of the ST segment elevation. This is the limit and Minnesota code. And because of this very much minimal margin, there is some mistakes of defining the ST segment deviation even by the cardiologist. And because of this, there may be 11% mistakes in different studies. I may mistake, you may mistake, everybody can mistake. That is, we can make, sometimes we can overdiagnose or underdiagnose because of some minimal changes. And this is the talk will be by Professor Abdul Kader Akanda. So this
Sir,
is the
Akanda sir has joined. Akanda sir has already joined.
So I can stop. So this is the ST segment limits, and let us join with Professor Abdul Kader Akanda. He is our scheduled speaker today. Professor Abdul Kader Akanda already introduced by our Abdullah Jamil, but I am requesting again Professor Abdul Wadud Chowdhury, please introduce Professor Abdul Kader Akanda. Professor Abdul Wadud Chowdhury.
কাদের ভাই আপনার এটা ওপেন করেন। হ্যাঁ, এই যে আসছে। আসসালামু আলাইকুম।
সালাম আতার ভাই, আসসালামু আলাইকুম।
আসসালাম কাদের, হ্যাপি টু সি ইউ।
দেখতে পাচ্ছি।
আচ্ছা, ওয়াদুদ
কেন
চৌধুরী,
অডিয়েন্স
মনে হয় যে আপনার লেকচারটা কন্টিনিউ করেন, কারণ আপনার মাঝপথ থেকে যেটা আসছে আমি খুবই এনজয় করলাম। আপনার এই মানে খুবই ভালো একটা টপিক ডিসকাশন, যে এসটি সেগমেন্টের যে ডেভিয়েশন,
এটা বললাম মানে দিস ইজ রিলেটেড টু ইওর টক, সেইজন্য আমি এটা
না খুবই ভালো ইয়ে করছেন। আমার মনে হয় যে আপনি কন্টিনিউ করেন, আমি শেষের দিকে যে আমার লেকচারটা অল্প সময়ের মধ্যে আমি ইয়ে করব।
না কোনো সমস্যা নাই। ইউ আর দা মানে অ্যাকচুয়ালি আওয়ার পার্টিসিপেন্টস আর ওয়েটিং ফর ইউ। প্রফেসর আব্দুল কাদের আকন্দ, প্লিজ ইন্ট্রোডিউস।
হ্যাঁ, আসসালামু আলাইকুম। Dear audience, Professor Abdul Kader Akanda is one of our senior teachers. He has retired as head of the Department of Salimullah Medical College, and he's known as a very good orator and in-depth analyzer of topics related to cardiology. I hope we are going to enjoy his talk on today's subject. That's why we do mistakes in diagnosing in acute coronary syndrome. Professor Abdul Kader Akanda, sir, would you please start?
Thank you, Professor Abdul Wadud Chowdhury, for your kind introduction. Actually, today, one thing I felt that the ECG study group is very much essential for স্ক্রিন শেয়ারিং অপশনটাকে আমি খুঁজে পাচ্ছি না।
Slide share.
আর নিচের প্যানেলে দেখেন একটা গ্রিন অ্যারো আপ আছে, ওটাতে ক্লিক করুন।
চলে আসছে। হ্যাঁ, মাঝে মাঝে মানে অনেকদিন পর জয়েন করলে যেটা হয় যে আমরা মাঝে মাঝে ভুলে যাই হাউ টু ম্যানেজ। তো এনিওয়ে, at the beginning of the talk, I express my thankful gratitude to Professor Atahar Ali and Professor Abdul Wadud Chowdhury for giving me the opportunity to talk something in front of this learned gathering. And I can see Dr. Jamil, he has got keen interest in the field of electrophysiology. So ECG basically represents the electrical activity of the heart. The activities, those may be converted to electrical signal, only those are recognized in ECG. And to me, it appeared that there are many signals are being produced in the heart, and some of the signals are documented in the ECG machine. And the signal which has been documented in the ECG machine, our brain do not receive all the signals. Only a small part of the signal we can interpret, and which we interpret thinking that we are in right track may not be right in truly that may not be right. So if we look at this iceberg, the only small part of the iceberg is visible. Only in our open eyes, we can see the shell of the upper part of the iceberg. We do not know what are the things remains inside the core of the upper part of the iceberg that is visible.
কাদের ভাই, আপনি কি ওয়াইন গ্লাসে একটু ইয়ে দিবেন, তাহলে আরো বড় হবে।
Although, thank you. So this is the iceberg. Only we can see the small part of the iceberg, and by our open eye we can see only the covering shell, and we do not know the inside. So ECG is like that, and today I thought the ECG study group should develop and should go forward and should be involved in research work to find out the unknown signal of the ECG that is being documented in electrocardiography machine. And also this study group has got the chance to document some of the signals which the ECG machine is not documenting by upgrading the ECG machine. So in introduction, just I will talk few words in the management, but the title was the what mistakes we are doing in the diagnosis of acute coronary syndrome. So acute coronary syndrome diagnosis is made by the clinical part and by enzymatic evidence. So today we will highlight what are the mistakes we are doing to interpret the ECG in a patient of acute coronary syndrome. The chief complaints of the acute coronary syndrome is the chest pain that accounts for more than 8 million of emergency department visits annually. Only a fraction will actually have a coronary syndrome. On emergency department presentation.
Please mute everyone else except the speaker. Please mute everyone else.
On emergency department presentation, fewer than half of patients with a clinical history reminiscent of acute coronary syndrome will have a truly diagnostic ECG finding. The other half will have some signs of ischemia, some non-specific ST segment and T wave changes, and some will show completely normal ECG despite having coronary artery disease, and truly it is acute coronary syndrome. So less than 1, in most of the cases, we see that 1 millimeter or 2 millimeter ST elevation is significant. But when there is equal to or less than 1 millimeter ST segment elevation or depression with or without reciprocal changes, these groups are actually the challenging group of patients for the diagnosis of the acute coronary syndrome. What will be the actual diagnosis and what should we do for this group of patients? An unchanged overall miss rate in acute myocardial infarction is about 2%. That is, in acute myocardial infarction, the ECG may not show any actual evidence at the initial part. So what common mistakes we are doing in the diagnosis of acute coronary syndrome by ECG? So any change, our normal interpretation is any change in single lead is normal. That is the big term in ECG interpretation. So any change in single lead is normal. But even in isolation, certain ECG findings can suggest danger. Such is true in lone T-wave inversion in AVL, known to precede an inferior myocardial infarction. That means that though we know that any change in single lead is normal, kintu kisu kisu khetre samanyo change at a lone T-wave inversion in AVL that appears as the normal finding, we do not give attention to that part of the ECG, but it may be the signal that the patient is going to develop inferior myocardial infarction. So in every change, we have to put our attention to that. We have to interpret. Similarly, sometimes as ordinary as upright and tall T waves or biphasic T waves can be the only marker of ischemia. The tall T wave, we do not care for that. Upright T wave, where it is normally inverted like in V1. These are the findings that do not draw any attention in our interpretation system. So if there is any change like that, that may be a marker of ischemia, we have to keep it in mind in future interpretation of the ECG. And ECG abnormalities, however, subtle, should give pause and merit careful inspection, since misinterpretation occurs in 20 to 40% misdiagnosed myocardial infarction. An upright T wave in V1 is considered as normal variant. When T wave is upright and large in V1 and taller than the T wave in V6, that means there is loss of precordial T wave balance. And this is one of the features of ischemia and may help in the diagnosis of acute coronary syndrome. Biphasic T waves, an initial positive deflection followed by the terminal negativity in leads V2 and V3 is highly specific for subacute stenosis of the left antero descending artery. This pattern is indicative of Wieland's syndrome and should consider invasive procedure, and we should avoid the provocative test in this kind of patient. We should not go for any provocative test in this patient because the patient has got subacute stenosis of the LAD, and provocative test may lead to development of acute myocardial infarction. Another important issue is posterior myocardial infarction that is missed and in many of the cases, but isolated posterior infarction occurs in lower frequency. It occurs up to 5% patients, but most of the occurs in, but majority occurs in conjunction with inferior myocardial infarction or lateral myocardial infarction. And ECG finding of the posterior myocardial infarction is very important because this is a category of ST elevated myocardial infarction, but the diagnosis is made by the ST segment depression. That is important in posterior myocardial infarction. So that is the ECG finding. Though there is ST depression, but we diagnose it as ST elevated posterior myocardial infarction. So in ECG of the posterior wall acute myocardial infarction shows the ST segment depression in V1 to V3, maybe up to V4, with tall R wave and upright T wave in V1, and the T wave in V1 is greater than T wave in V6. And if this ST elevated MI, posterior MI is in doubt, then we can do the posterior ECG leads. We can place the posterior ECG lead, that is the lead V4 to V6 in the left scapular region. And if in these three leads, if there is only 0.5 millimeter ST elevation in any one of these three leads, is diagnostic of posterior wall myocardial infarction. So posterior myocardial infarction involves a small myocardial area. So if we consider the involvement of the myocardium, it is not significant at all. But this small amount of myocardium that is involved in posterior myocardial infarction results in moderate to severe mitral regurgitation. That is an independent predictor of long-term heart failure and infarct-related mortality, and that occurs in up to 1/3 of the patient of posterior wall acute myocardial infarction. So precordial ST segment elevation due to normal variation are also challenges. I was listening the lecture of Professor Atahar Ali about the ST segment deviation, and that discussion definitely make this understanding of these changes are very easy. So ST segment diagnosis, myocardial infarction diagnosis, normal variant ST segment elevation and presence of left bundle branch block makes the difficulty in the diagnosis of ST elevated myocardial infarction. So in this kind of patients, we can say pseudo infarction like early repolarization, that is very clearly discussed by Professor Atahar Ali. I'm not going to discuss in detail. And left ventricular aneurysm, it involves the inferior surface, then it can produce the ST segment elevation in the leads that mimics with acute ST segment elevated myocardial infarction. Pericarditis. Pericarditis already discussed the concavity of the upwards. In pericarditis, there is involvement of there is ST segment depression in almost all leads except AVR and V1. In AVR there is ST depression in pericarditis, and when there is ST segment elevation in the inferior leads in pericarditis, then the diagnosis of inferior wall myocardial infarction becomes a differential diagnosis, and that is very difficult to differentiate between these two. But if we look at the ECG very carefully, we can make the diagnosis of the ST elevated inferior wall MI and pericarditis by looking at the amount of ST segment elevation in lead 2 and lead 3. In case of pericarditis, the maximum ST elevation occurs in lead 2 because the vector of pericardium is directed towards lead 2. That's why in pericarditis, there is maximum ST elevation in lead 2. But inferior surface vector is going towards the lead 3. That's why in inferior wall myocardial infarction, there is maximum ST elevation in lead 3. By this finding, we can differentiate the inferior wall ST elevated MI from pericarditis. But sometimes this diagnosis may be difficult when the inferior wall myocardial infarction occurs due to circumflex coronary artery involvement. Practically, that involves the inferolateral surface. So in that situation, vector may be directed towards the lead 2 and maximum ST elevation may be occur in lead 2. So in such situation, by this magnitude of ST elevation, we cannot differentiate the pericarditis from ST elevated MI. So we have to carefully evaluate the patient and clinical correlation. Other diagnostic tools can help to make the differentiation of this kind of ECG. In left ventricular hypertrophy, WVW syndrome, all of you know, sometimes it gives the feature like inferior wall myocardial infarction. Brugada syndrome, all of you know, though I understand very minimum about the Brugada syndrome. There are some ST segment elevation in precordial leads and mimics with myocardial infarction. And left bundle branch block, the diagnosis of acute myocardial infarction may be difficult, and that can be done by different modes that we are going to discuss. Left bundle branch block, if it is new, either it is new, documented new, assumed to be new left bundle branch block, or if the pre-existing left bundle branch block with carbo concordance, then we should consider as the ST elevated myocardial infarction. Isolated posterior wall myocardial infarction, the immediate, these are the findings that demands for immediate invasive procedure with reperfusion. ST elevation in AVR, though it is not very significant, involves a single lead, and it is mostly associated with ST depression in most of the leads. That indicates the involvement of the left coronary artery or multivessel involvement or equivalent to left main coronary artery disease. This group of patients should be addressed on emergency basis. The Winter's STT wave changes, that is also important. The Winter's STT wave means there will be some ST segment depression followed by ST elevation with tall peak T wave with almost equal height of ascending and descending limb of the T waves. So this is a very important finding, suggests significant stenosis of the left antro descending artery. And hyperacute T waves already discussed. I think these are the findings on where we should go for the diagnose, go for the early reperfusion strategy in this group of patients. So with this variation that came to my notice, I am showing some ECG tracing, and all of us will discuss on this ECG tracing, and you will give me the, what are the changes we are looking in this ECG? Can any learner or trainee doctor can answer? What are the ECG changes you can see in this ECG?
Systematically, anyone can raise your hand, please, volunteer.
No one?
Anyone? We have got Dr. Abida. Can you comment some? Dr. Abida.
Assalamu alaikum, sir.
Mm-hmm.
Sir, in this ECG, this is the 12-lead surface ECG, which showing that there is ST T-wave depression with STTT changes in 1 and AVL. Sir, this is the ST changes that I'm seeing. Other than that, sir, other leads, they're normal, sir.
Other leads appears normal. If you do carefully to lead 2, lead 3 and AVA, you can find the ST segment appears in the normal level
Yes,
or
sir.
the ST deviation is less than 1 millimeter. So
Yes,
this
sir.
group of patients are the challenging group of patients in our clinical practice, where there is the morphology appears as ST elevation, but its ST deviation is less than 1 millimeter. So this kind of ECG is actually the challenging. Actually, আমার যে প্রেজেন্টেশনে দুইটা যদি লেখাটা না থাকতো আমি সাজাতে পারি নাই আর কি। আমার যে স্টেপ ওয়াইজ গেলে এই ইসিজি গুলো ইন্টারপ্রিটেশনটা ভালো হতো। আচ্ছা লেখা দেখেই বলো, একজন একটু বলো দেখি এটা ইসিজিতে কি আছে। লেখাটা না দেখে অনেস্টলি একটু এই ইসিজি সম্পর্কে একটা কমেন্ট করো দেখি।
Anyone volunteers from Nepal?
আমরা থিওরিটিক্যালি ডিসকাস করেছি, তার মধ্যেই ইসিজি ট্রেসিংটা দেখানো হচ্ছে যে আমরা এই ট্রেসিংটা সম্পর্কে আমরা কিন্তু ডিসকাস করেছি। তুষার কোনো ভলেন্টিয়ার আছে? লেখা আছে তারপরেও।
So again, Abida, you can comment. No problem, Abida. Welcome.
Sir, here I can see that there is that the T waves in sir lead V2 to V2 to V4, 5. It looks that there is hyperacute T, and there is also, sir, into AVF. I can see that there is some ST depression. So, sir, this may be a case of acute coronary syndrome. Maybe we can comment that it may be acute ST elevated MI. Serial ECG is required, sir, to comment.
Abida, একটা জিনিস খেয়াল করুন। Whenever we are talking about a hyperacute T, the
Yes, sir.
most important thing is the ST segment will not be starting from the baseline.
Yes,
It will
sir.
be started higher up.
Higher up.
But here, there is ST segment depression with T wave going up and up and up very sharply.
Yes, sir.
That's not typical acute hyperacute T wave in here. This is a very typical characteristic of deep winters. There will be ST segment, ST junctional depression with rapid ST segment elevation and resulting in a very tall, narrow-based T wave.
And one comment I'd like to make. All the participants, please look at the ECG and put in your mind. The reason being, sometimes we call it like upsloping ST changes. Upsloping ST changes, we call sometimes benign when you do a stress test or something like that. Normally, horizontal or downsloping is more significant. But if you understand the pathophysiology, when the coronary arteries gets occluded, thrombus forms initially. In the very beginning phase, you don't see much ST changes, ST elevation. You'll see hyperacute T wave. Because when you, anybody who works in the cath lab or cardiology fellows who is doing the heart cath, they saw that when you inflate the balloon in the coronary artery, you see that the hyperacute T waves. So this is the very initial phase of acute coronary syndrome, acute occlusion of the artery. And then, and particularly here, the ST depression there, but the hyperacuity of the T wave may tell you this patient is having acute occlusion. And if you repeat the ECG, like 15-30 minutes later, you might see the ST elevation later on this particular patient. So don't confuse with the, we call upsloping ST changes, but if the upsloping ST changes, it associates with the hyperacute T waves. Think in your mind about De Winter syndrome, and definitely clinical consideration. What's the clinical situation of the patient? You need to always look at it.
Kader bhai.
আমার মনে হয় যে it is very right. This is the ECG that is termed as the De Winter's T waves. This is the classic ECG of De Winter's T waves that represents the acute occlusion of the left antero descending artery. And very right, the changes that occurs in ECG, in my experience, I had the experience of stent thrombosis in two patients. One patient in 2009, that patient developed stent thrombosis on third day. Before discharge, on the day of discharge, she developed chest pain. ECG showed mild ST depression in lead 1 and AVL with T inversion. There is no other significant changes in the ECG. But when we took the patient to cath lab, I found the LED is totally occluded. And 2016, I found another patient. I did completed PCI at 4 o'clock. I came to my chamber. At the end of my chamber at around 10 o'clock, the doctor from CSU of lab called me that your patient developed severe chest pain with sweating, and ECG does not show any significant changes. In that patient, that was a complex PCI, bifurcated lesion, LED and diagonal branch. And so when I went there, I found only T-wave inversion in lead 1 and AVL. No other changes. That occurs few minutes. Within few minutes, I arrived to the CCU. So only change is T inversion in lead 1 and AVL. I thought that diagonal branch has been occluded. But when I took the patient to cath lab, I found the totally occluded left ventral descending artery, and that was recanalized. Now the patient is okay, and there was no significant ECG change after second procedure of that patient. So in the early phase of the acute coronary syndrome, the ECG changes basically maybe misguided. Last night, I had one patient in my chamber. Age is 32 years, a liver donor to his mother. Came to me with chest pain, told me that I experienced chest pain last night. Late part of the night, I had chest pain. And sometimes I'm getting chest pain, but no relation with exertion. I asked him how much you can walk. Well, I can walk for up to 1 hour without any symptom. So naturally, I thought it is not a acute case of acute coronary syndrome, and ECG was absolutely normal. Normotensive, non-diabetic. Only factor was that he was maintaining stressful life after liver donation. And his mother also died during the liver transplantation. So that was the frustrating part, stress. Otherwise, he had no significant risk factor. Last night at 3 o'clock, I got a call from Labit that the patient admitted with acute anterior myocardial, ST elevated anterior myocardial infarction. So this kind of patients, sometimes the clinical presentation as well as the ECG finding, both may be misleading. And in this ECG, this is a very different morphology from the hyperacute T-wave and different morphology from ST elevated myocardial infarction. Here, there is ST segment depression at the initial part of the depolarization, followed by the ST elevation, merges with the T-wave with almost equal limb, ascending and descending limb of the T-wave is almost equal. That is present from V2 to V3, V4, up to V4, it can present. So it is a classic feature, and it is the representation of the acute occlusion of the left anterior descending artery. Anyone can pass comment on this ECG?
Sir, may I try, please?
Yeah, please.
Sir, here in this 12-lead surface ECG is showing there is ST elevation in lead AVR, and there is DST depression in the lead, all the leads, like more than 8 leads, both chest and limb leads. So it may be a case of acute equivalent to acute ST elevated myocardial infarction.
It is not equivalent to ST elevated myocardial infarction. This is a very classic. Sometimes we tell it as forgotten lead. It is the forgotten lead, that is the AVR. If you look at the ECG, most of the leads shows ST depression, except AVR and V1. There is ST segment elevation prominent in the AVR and also mild ST elevation in V1. So in such situation, we calculate the elevation of the AVR is higher than the V1, and this kind of ST depression represents, what does it represent?
So
We discussed it earlier. Probably it involves the left main or left main equivalent lesion. It is not the ST elevated myocardial infarction. It is the representation of
left main equivalence.
Left main or left main equivalent lesion. That's why there is ST depression in lead 1, lead 2, lead 3, AVF, and also ST depression from V3 to V6. So most of the leads, there is ST depression, only mild ST elevation in V1 and ST elevation in AVR. This is one of the classic ECG finding of acute coronary syndrome. Anyone in this ECG actually, I could put the statement later on. But anyway, even with this statement, anyone can put any decision on this ECG. Any comment?
Sir, sir, many a times that STT changes in V1, V2 makes us confused, or the juniors, those who juniors like us or mid-level, get confused with this ST depression. Sir, just if there is chest pain and ST depression in V1, V2 with upright T, can we straightway comment posterior myocardial infarction without involvement the 2-3 AVF?
You can say it, because if you look at the statement that I discussed, the posterior wall myocardial infarction isolated frequency is low, up to 5%, and posterior myocardial 95% occurs in association with inferior wall myocardial infarction or inferolateral infarction. So if there is ST segment depression in V2, V3, or sometimes it may be V4, associated upright T wave in V2, V3, and this T wave, if it is greater than the T wave in the V6, that is a strong suspicion for the diagnosis of posterior wall myocardial infarction, isolated posterior wall myocardial infarction. But if you doubt in the diagnosis in such cases, you will put V4, V5, and V6 lead in the left scapular area. And if there is ST segment elevation up to 0.5 millimeter in any one lead, not 3 lead, any one lead, if show ST segment elevation up to 0.5 millimeter, that is diagnostic. That is the confirmatory ECG finding for posterior wall myocardial infarction. So this kind of ECG represents the true posterior infarction.
Kader. Hello, Kader. Professor Abdul Chowdhury is a master of this kind of the ECG. My question is,
Right.
Chowdhury is a master of posterior. Professor Kader, does this patient fulfill the criteria of thrombolytics? This patient?
Yes. Yes, this is one of
This
the
is not
situation.
only,
You follow the
it-
guidelines, they will say this is the situation where you can go for thrombolysis.
And also to prove that point, definitely you can do the posterior ECG, see the
Yes.
ST elevation, do it. Yes.
This is one of the indication for the early reperfusion therapy. We have to consider যে কতগুলো প্যারামিটার আছে তার মধ্যে this is one of the parameter. যে এইটা ইনভেসিভ মানে এটা রিপারফিউশন করতে হবে. Whatever the mode of reperfusion, maybe thrombolytics, maybe invasive, anyway.
So which artery is commonly involved this kind of the ECG, Kader?
Wadud Chowdhury,
স্যার এটা সার্কামপ্লেক্সে সাধারণত পাবে
circumflex এর ওয়েব
সাধারণত।
মান্স থেকে
কারণ isolated posterior MI without involving the inferior leads
anterolateral
is very unlikely in case of
in up to 5%.
left dominant right dominant system. Very rare. But in case of left dominant system, it involves the circumflex posterolateral artery, posterior ventricular artery. That's very important. The most important thing already been said. You have said it because it supplies the posterior medial papillary muscle dysfunction that leads to MR, and so acute inferior MI with posterior involvement, posterior extension is bad. Acute posterior MI in isolation is also bad because of the presence of MR, and that leads to more chance of LVF and LV dysfunction.
Right. So we have to look at this very carefully in a patient of inferior and inferolateral myocardial infarction to identify the posterior. মাঝে মাঝে অদুদের উপরে করতাম অদুদ এত পোস্টেরিয়র উপরে এত ইন্টারেস্ট তার কেন দেখলাম যে দিস ইজ এ স্মল টেরিটরি বাট ইট ইজ এ ইম্পর্টেন্ট পার্ট দ্যাট ড্রজ আওয়ার অ্যাটেনশন
Yes.
এটা আমাদের খুবই ইম্পর্টেন্ট একটা ইসিজি ফাইন্ডিং পোস্টেরিয়র ওয়ালকে আমাদের খুব অ্যাড্রেস করতে হবে দিস ইসিজি এটা আর মনে হয় যে সিম্পল হয়ে যাচ্ছে আর ডিসকাশনই যায় না
স্যার এই আগেরটা একটু যাবেন whenever you are in doubt that the ST elevation we are seeing in inferior lead is important or not, look at the ST depression in AVL. If it is present, this is very likely to be a real acute ST elevated inferior MI.
That is
This
the
reciprocal
message
change
it
is the key to your proper diagnosis. Adis bhai.
Now, I totally agree with that because reason is, you can see if you look carefully, look at that lead 3 AVF, there's question about how the ST look like. Okay. And also if they coexist with TUV inversion, ST depression, TUV inversion, AVL, one in AVL particularly, you need to be more serious. And if you have any questions, sometimes definitely clinical scenario is there. You have to always take into account. But in this situation, if you have, normally, I think this is good enough for me to diagnose acute event, okay? But if you have doubt, repeat the ECG in 15 minutes later, you'll see a difference in this patient. Possibly, okay?
Sir,
But
sir, there is a question that
Mhm.
presence of ST depression, is it a must or is it related anyway to prognosis?
Depends on what is the ST depression.
The reciprocal changes, ST depression, the reciprocal ST depression that we often classically said that in case of anterior MI, there will be reciprocal changes in inferior leads, and in case of inferior MI, there will be reciprocal changes in anterior leads. Is it a necessary? Or is it a must?
It's not a must, but we expect that, but according to the position of the electrodes that we have in anterior posterior area. Okay, if it is there, it confirms your diagnosis more. And it also probably reflects the myocardium in jeopardy, how much myocardium in jeopardy, okay? That can, define that area that you're seeing some reciprocal changes. But I don't think it's a must.
Yeah, it's not a must, but it always helps to determine whether it's actual or not. And one thing is that whenever you are not sure, say a patient is giving a history of chest pain for last 24 hours, but you are getting reciprocal change, actually the patient was having unstable angina that has resulted in recent acute MI, acute ST limited MI. And probably the patient is in the zone of thrombolysis. That helps. Reciprocal change do not last too much. If it is there, that means the patient in our country, because we do not have primary PCI, you can give thrombolysis to the patient.
So there is a question in the chat box that is there reciprocal change due to ischemia or only because of the lead position?
That's a difficult question thing to answer, because even the experts are not very sure which way to go.
And another thing that we need to understand, sometimes it complicates how the anatomy of the artery. Okay, as for example, like if you're LAD, we expect that anterior ST elevation occlusion and inferior probably depression, you might expect that. But if the LAD is way big enough, wrap around LAD, that will definitely complicate the scenario. So you might not see that classic reciprocal change that you expect. Rather, you see some sort of elevation in that area because it's supplying that apical even going to the part of the inferior area if it's a big LAD. Or if it's a right coronary artery is huge, wrap around and going to the part of the anterior area, that can also complicate that. So it depends on anatomy, and also depends on the how much blockage you have in other arteries. Okay, so they might have a coexistent blockage in other arteries, like 60%, 70% blockage. They might be getting, if they have dominant artery going to that area and right coronary artery has some 70% disease, that will complicate also the classic picture that we expect. Yes, there's always exception because of these reasons. But in a normal way, you expect that, but you don't expect to see them all the time. Yes, that is correct.
কাদের ভাই আপনার ছোট্ট একটা এসিজি অনেক ডিসকাশন করে দিল আপনি আগান
reciprocal change basically in past when we were student the reciprocal change was considered as a simple that may be due to placement of the leads, but nowadays the reciprocal change does not mean that it is the similar as with or without reciprocal change. When there is any reciprocal changes, that indicates the more extensive disease and there is chance of involvement of the multivessel rather than single vessel. This ECG
Tushar, any volunteer or you? Either volunteer or Tushar, you. Very difficult. This is very minimal sense, Kader.
এটাই যে আমাদের জন্য এটা খুবই ডিফিকাল্ট হয়ে যায় sometimes we miss the diagnosis and at a glance it appears as the normal ECG, but
very minimal change. Yeah, very
minimal change. That is the T wave in V1 is upright, broad, and this T wave is larger than the T wave in V6. So this is one of the evidence of ischemia. So this kind of patient, if presents with chest pain suggestive of acute coronary syndrome, should be considered it as acute coronary syndrome. If the T wave is upright in V1, V2 and taller than the V6, that is one of the important findings.
That is in presence of the symptom upright T1, that is the T in V1, that is
V1,
taller than
V2
the V6.
upright T wave is considered as pathological. If there is symptom, definitely it should be considered pathological. But we have to compare the T wave in V1 with the T wave in V6. Normally, the T wave is taller in V6 than in V1, V2. Normal patients, the T wave is inverted.
Whether this changes even comes earlier than the enzyme, Kader, this kind of the minimal
Only
change?
this represents that it is the evidence of ischemia. And I do not know the comparative study with other changes, whether it precedes the development of the ST segment elevation or not. That is not mentioned. It did not come to my notice. But this is the change that we have to consider as a case of acute coronary syndrome, and we have to treat the patient accordingly.
So what you are saying that we do not expect a very good, beautiful T wave in V1 normally.
Right.
But if it is there, we have to pay attention.
We have to give attention.
Pay
That is
attention.
important.
Look
That
at
is
the clinical scenario, look at the other ECGs, look at the reciprocal changes, and then give a decision.
Right.
And I'd like to make a comment. This WKG that makes us difficult in the emergency room to decide what way to go. That is absolutely correct. So when a patient comes with chest pain in the emergency room, you have to really think about what's the pretest probability of acute coronary syndrome in this patient, okay? And look at the scenario, the TME13 criteria or, some other criteria to define that, what's the pretest probability of acute coronary syndrome. ECG is one of the factor, not the only factor, okay? You have to look at the clinical scenario, you have to do the exam, whether there's any new heart murmur or anything going on. Definitely then ECG comes into role. And then the heart enzymes comes into role. But heart enzymes always delayed, if it's acute situation, it might delay 2 hours or 3 hours to get the results back. But the question right now, that if the pretest probability is high, then this WKG should bother you. Do not let the patient go, okay? That's the clinical scenario is extremely important. That I'd like to make sure that our all trainees keep in mind. Because if this patient comes to me with this ECG, just only the ECG, definitely I'll not say that something like we have to take him to the cath lab right now, unless I know the clinical scenario, what's going on with the patient, what's the pretest likelihood of the patient having true acute coronary syndrome. So don't miss the clinic, okay? And also, yes?
I want to add that if you get such an ECG, ask for any previous ECG available. That will help you to compare with the previous ECG, whether this is a new change. That will also help you.
Beautiful ECG.
Always we can compare the ECG with past one. That helps us in making the diagnosis, what are the new changes. That is very important. And clinical judgment is also important in every patient, in every case. Next question to anyone. This is
That's
a
good
very
EKG.
massive ECG. Sometimes we are getting in our practice as well. I am afraid of this kind of ECG. It becomes difficult to make the diagnosis. Sometimes decision may be difficult. This kind of ECG change will persist for days together. Anyone?
Mr. Sushanto Borua has raised hand.
Yeah, welcome.
Amul bhai, can you make him panelist so that he can speak?
Sushanto Borua. তুষার
হ্যাঁ রিভু
আর কেউ বলার?
So before that, Kader, whether this kind of ECG can present without symptom?
Without symptom, anyone can present without symptom because some patients develop silent myocardial infarction. So in those group of patients where there is loss of pain perception, those group of patients might present without chest pain. Otherwise, this is the patient will present with chest pain, typical chest pain of acute coronary syndrome.
If there is no facilities for the cath lab, whether this patient fit for the thrombolytics?
Actually, if there is no facilities for the cath lab, then we have to go for the standard medical management rather than thrombolytic therapy. Because this is the finding that represents. Tushar ki bolte parben, what does it represents? This ECG.
This is very specific for proximal LAD involvement.
Tushar, Abida ki bolte parben kisu?
Sir, here I can see, sir, in lead V2 and V3. So the T wave, there is if TT changes, the T wave looks biphasic T wave, which is typical of Wieland's syndrome.
Yeah.
আপনার প্রশ্ন যেটা আসছে আবিদা ওইটুকু বলেন যে এখানে ক্যাথ ল্যাব নাই, তাহলে এই ইসিজিটাতে আমাদের দুইটা জিনিস আপনার চিন্তা করতে হবে। ক্যান উই গো ফর thrombolytics? That is one of the question that is asked by the.
No, sir, we cannot go for the thrombolytic.
Why you will not go for thrombolytic therapy in such patient?
So because, sir, here I can see there is biphasic T wave, but without, actually there is no clear-cut ST elevation or in any way.
Actually, in this ECG, termed as the Wieland syndrome, biphasic T waves occurs in V2, V3, sometimes V4. If you look at the ECG, they are upright T followed by the downsloping. This is the biphasic T wave. Some people might consider it as E wave, maybe confused with E wave, but it is not E wave. It is the upsloping T followed by downsloping, up and down. So both slope is there and minimal ST segment elevation. This is the evidence of subacute occlusion of the left antrodescending artery. In subacute occlusion, we never use thrombolytics. So it is in ST elevated MI or unstable angina equivalent. We cannot use thrombolytics here. It is subacute occlusion. And this is the ECG where you should not go for stress evaluation.
Yes.
You should not go for stress evaluation. That is contraindicated.
This is very important.
That is very important.
That's very important.
Kind of ECG, if you find in your life, do not go for any stress evaluation. That is contraindicated.
Actually, this is the change with in the scenario. They need invasive procedure as early as possible.
Right.
Please do not send the patient for ETT. Do not do that.
So I think I covered the one side of the visible iceberg, and lot of things remain beyond my vision. The what mistakes we are doing in our practice, I just focused on some of the EKG where we might miss the diagnosis that came to my notice. I discussed on that. Lot of mistakes we are doing in every day, especially when the ECG is normal in a patient with suspected acute coronary syndrome. That is the most important mistake we are doing everyday practice. And at the end of my lecture, my conclusive appeal to the ECG study group is to concentrate the study of ECG in our population to discover something from the ECG recording. I think lot of things in ECG is unknown to us. We cannot receive the ECG signal in our brain. So this ECG study group is our hope that in future we will be able to get some new information from our study group and the nation will be benefited. Thank you, everybody.
It's great.
Thank you. Thank you very much, sir. It's almost 2 hours. And for that 2-hour period, our participants are very much
Nobody has left.
interested. Nobody has left the discussion. So it proves.
So the number is low. There
Sir,
should have
is-
been more. And today's discussion was very important, very important.
But sir, most of
really
them are
enjoyed
now, many of them are connected via Facebook Live. But the important thing is that we started the program with 50 participants. It goes and it remained as such. It almost remained as such. That proves the importance of his lecture, how much he gave so that the participants did not leave. I congratulate Professor Abdul Kader Akanda sir for his wonderfully constructed lecture. I would like to request Abdul Wadud sir and Atahar Ali sir to say their remarks about the program, about this lecture, and conclude the session.
আতার ভাই আমার দুটো অবজারভেশন ছিল যে আমাদের এখন কি নেপালি স্টুডেন্টরা আমাদের এখানে সংযুক্ত থাকেন, যদি না থাকেন দেন আই উড এক্সপেক্ট দ্যাট আমাদের ডিসকাশনটা বোথ ইংলিশ এন্ড বাংলা দুটোর মধ্যে যেন হয়, স্টুডেন্টদের বোঝার জন্য তাহলে খুব ভালো হবে। আর যদি নেপালি স্টুডেন্টরাও থাকেন তাহলে উই হ্যাভ টু টক ইন ইংলিশ।
আচ্ছা,
এটা আমাদের একটু কনফার্ম করা দরকার।
মাঝখানে গ্যাপের জন্য নেপালিরা একটু হয়ে গেছে, বাট আমার মনে হয় যে তাদের থাকাটা ভালো, তারা খুবই ভালোভাবে পার্টিসিপেট করে। আমার মনে হয় যে আমি দেখি মাস্কের সঙ্গে কথা বলে মাস্কে জয়েন করলে ওরা করবে আর কি। তো আমরা এক্সপেক্ট করি যে তারা জয়েন করুক, কারণ মানে রিয়েলি তারা খুবই ভালো একাডেমিক।
ভাই আপনার কনক্লুড করার আগে কি আমি একজন দেখতে পাচ্ছি ডক্টর আজিজুল হক।
আজিজুল হক,
আসসালামু আলাইকুম। আমি আপনার চিনি নাম হিসাবে, হ্যাঁ, your dedication, contribution and teaching in Bangladesh. Actually আমার জাস্ট এক ভাগ্নি এবার সলিমুল্লাহ মেডিকেল কলেজে চান্স পেয়েছে, হ্যাঁ। তার বড় বোন কিন্তু ডক্টর ওয়াদুদের ছাত্রী ছিলেন, এখন BCPS খুঁজছে ঢাকা মেডিকেল কলেজেই আর কি। It's a very wonderful lecture. The reason being, this is the things we miss all the time. কারণ আমরা যখন ইমার্জেন্সি রুমে যাই, আমরা যখন ECG দেখি, আমাদের একটা বিরাট রেসপন্সিবিলিটি যে এই পেশেন্টটাকে আমরা এখন ক্যাথ ল্যাবে নিব নাকি থ্রম্বোলাইটিক নিব, নাকি আমরা চিন্তা করছি যে না তাকে স্ট্রেস টেস্ট করব ফার্দার আন্ডারস্ট্যান্ডিং অর এটিপিক্যাল চেস্ট পেন বাসায় পাঠিয়ে দিব। এই জিনিসটা আমি আমার স্টুডেন্টদের দেওয়ার চেষ্টা করি। হোয়াটস দ্য প্রি টেস্ট likelihood the patient is having acute coronary syndrome? Very important concept, and different way you can distinguish that. Second, আমরা as a physician আমরা সবসময় চিন্তা করি আমি যেন মেজর থিং মিস না করি, হ্যাঁ, যেটা আপনি ওয়ান্ডারফুলি দেখিয়েছেন, যেগুলো আমরা মিস করি সাধারণত আর কি, পার্টিকুলারলি posterior MI, হ্যাঁ, posterior MI that is the most missed diagnosis. And you're absolutely right, 2% of patient from the emergency room is being discharged, 2% of a patient come back with acute heart attack or acute MI. So ER physicians are very nervous sending those patients home. And তারা যথেষ্ট চিন্তা ভাবনা করে কিন্তু তারা ছাড়ছে, যথেষ্ট ইনিশিয়াল ইনভেস্টিগেট করে তারা ছেড়ে দিচ্ছে, কিন্তু still 2% patients they have heart attack, they come back with heart attack or they die at home. So we are very careful, not to miss those things. And you wonderfully আপনি দেখিয়েছেন যে কি জিনিসগুলো আমরা মিস করি। হ্যাঁ, তো কিছু কিছু ভিজুয়াল রিপ্রেজেন্টেশন আমি বলবো যে আমাদের স্টুডেন্টদের মাথার মধ্যে রাখতে, পার্টিকুলারলি দ্য ওয়েলেন সায়েন্স, ডি উইন্টার সিনড্রোম অ্যান্ড পোস্টেরিয়র এমআই। হ্যাঁ, এবং কোনো সময় যদি সাসপিশন থাকে কিন্তু আপনার clinical correlation is very high, then do an ECG 15-30 minutes later. You will see some changes if it's acute coronary syndrome. When it was not clear before, it will come up in the next ECG. And I have many cases that we are waiting and see, boom, 15 minutes later, acute ST elevation MI. Okay, I had to take the cath lab. I was thinking about putting him in the ICU or telemetry to just monitor the patient, but I have to change the mind in 15-20 minutes later to send him to the cath lab right now. So always be careful. Don't leave the patient that আপনি দেখেছেন পেশেন্টটাকে, ডিসিজি করলেন, ডিসিশন নিয়েছেন, এবং don't forget the patient. Ask the nurse how the patient is doing. 10-15 minutes later, give them a call again. যে কি পেশেন্টটা কি কোনো ধরনের নতুন সিমটমস হচ্ছে কিনা, রিকারেন্ট সিমটমস হচ্ছে কিনা। যদি স্টুটারিং অ্যানজাইনা হয়, স্টুটারিং চেস্ট পেন হয়, forget the ECG. Your suspicion is very high. Very high, the patient is having acute coronary syndrome. So এই ধরনের কেসগুলো যেগুলো আপনি দেখিয়েছেন আজকে is very beautiful, এবং আমি চাচ্ছি যে আমাদের স্টুডেন্ট যারা পার্টিসিপেট করেছেন তারা এটা ব্রেনের মধ্যে রাখবো, কারণ যারা কার্ডিওলজি করবে তাদের কিন্তু এইগুলো প্রতিদিনই ফেস করতে হবে। হ্যাঁ, and these things we should not miss, and it's wonderful discussion. Thank you.
All right, before you conclude, just ছোট্ট একটা কমেন্ট। আমি শুরুতে বলছিলাম যে আব্দুল কাদের আকন্দ is a very good teacher, and he proved today by his lecture, and he's a very keen observer, finding out the subtle changes. Those are very important.
আমার মনে হয় যে প্রফেসর আব্দুল ওয়াদুদ চৌধুরী কনক্লুড করবে, তার আগে আমি বলি যে আমার মনে হয় যে আমাদের আব্দুল কাদের লেকচার, প্রফেসর আব্দুল কাদেরের লেকচার আসলে শেষ হয় নাই। এটা আসলে শেষ হয় না, কাদের স্যার এটা শেষ করতে পারে নাই। আমি আমাদের পার্টিসিপেন্টের পক্ষ থেকে বলছি, কাদের স্যার, রিকোয়েস্টিং ইউ টু ফিনিশ ইউর লেকচার ইন অ্যানাদার ডে। আমার মনে হয় যে অনেক কিছু দেখানো বাকি ছিল, সময় স্বল্পতা আছে। ইউ ক্যান, আমার মনে হয় যে এটা ভেরি ডিফিকাল্ট টক। আমি এই টপিকটা সিলেক্ট করার আগে কাদেরকে রিকোয়েস্ট করছিলাম, অনেকে এই টকটা দিতে চায় না, যে ইট ইজ ভেরি ডিফিকাল্ট টক, এবং এত নাইসলি এটা প্রেজেন্ট করা হয়েছে যে আনবিলিভেবল, আমার ধারণা ছিল না যে এই সমস্ত জিনিসগুলো, যে বিষয়গুলো আমরা মিস্টেক করি, রিয়েলি আমার মনে আছে যে আমি কতগুলো মিস্টেক করছি। সেজন্য আমি কাদেরকে রিকোয়েস্ট করব, ইউ প্লিজ কন্টিনিউ ইউর টক। আমরা আবার নেক্সট ডেতে এই টকের আরো ফার্দার যেটুকু বাকি আছে শুনতে চাই। ইউ হ্যাভ নট ফিনিশড ইউর টক। কাদের, কনগ্রাচুলেশন, থ্যাংক ইউ ভেরি মাচ ফর দিস লেকচার।
কাদের ভাই, আসলে এই জিনিসগুলো না আমি খুব ফিল করি যে এই যে আমার একটা অবজারভেশন হলো, এনআইসিবিডির নন এসটিএমআই যা ডায়াগনোসিস করা হয় তার 30% হলো অ্যাকচুয়ালি পোস্টেরিয়র এমআই, যেটা মিস করে লোকজন। এখন কিন্তু তারা মিস করার ডিগ্রিটা কমে আসছে, এবং এটা বলা হচ্ছে কিন্তু যে সন্দেহ হলে ইউ হ্যাভ টু ডু দ্য পোস্টেরিয়র লিড, ইউ হ্যাভ টু ডু দ্য রাইট সাইডেড লিড। এই জিনিসটা আজকে লেকচারটা খুব চমৎকার একটা লেকচার।
আপকামিং কনফারেন্স, আই এম ইনভাইটিং এভরিওয়ান টু জয়েন our upcoming conference on 24th September. তো অদূতকে আমি স্পেশালি রিকোয়েস্ট করব টু প্রিপেয়ার এ লেকচার the posterior myocardial infarction
really
in
nice selection. He is a real master.
অদূতকে আমি মানে টপিক মোটামুটি হয়তো সাজায় গোছায় দেওয়া হবে। অদূত এখন থেকে একটু লেকচার রেডি করো যে পোস্টেরিয়র এমআই এন্ড হার্ট ফেলিওর। আমার বেসিক্যালি আমার যে কনফারেন্সটা হবে হার্ট ফেলিওর, তো এখানে আমাদের প্রিভেন্টিভ অ্যাসপেক্টে আমাদের থাকবে, করোনারি ইন্টারভেনশনও থাকবে, জামিল আপনার ইলেকট্রোফিজিওলজিও থাকবে, যে রোল অফ ইলেকট্রোফিজিওলজি ইন হার্ট ফেলিওর। এগুলো বিভিন্ন টপিক একটু আপনারা নিজেরা সুচিন্তিত মাঝে একটু সাবমিট করেন আমার কাছে, আমরা তাহলে আপনাদেরকে সেইভাবে লেকচার গুলো দিতে পারি। হ্যাঁ, আমাদেরকে একটু
কনভার্সন করে দিছে ইয়ে করে ডিসি শক দিয়ে।
একটু বলেন আপনার ডক্টর আইজুল, আপনার যদি কোনো টপিকে ইন্টারেস্ট থাকে আপনি তো ইন্টারভেনশনে কাজ করছেন।
না আমি ইন্টারভেনশন আমি জেনারেল কার্ডিওলজিস্ট হ্যাঁ
তো
না হার্ট ফেলিয়ার আমার I have high interest in heart failure.
Adil bhai অনেক
হার্ট
ইন্টারেস্টেড
ফেলিয়ার
আছে।
হার্ট ফেলিয়ার ইলেকট্রোফিজিওলজি নিয়ে যদি
So
আপনি
try to participate in our program. I will collect your number and we will try to
আমি পাঠিয়ে দিব।
আপনি যদি কোনো টপিক থাকে আমাকে দেওয়ার মতো আপনার পছন্দের আমাকে দিয়ে দেন আমি প্রিপেয়ার করব।
আচ্ছা
আপনি ওই যে ফ্ল্যাটারটাই করেন আপনি অ্যাট্রিয়াল ফ্ল্যাটার অদূর যেটা বললো অ্যাট্রিয়াল ফ্ল্যাটার কন্ট্রোল অফ অ্যাট্রিয়াল ফ্ল্যাটার রোল অফ কন্ট্রোলিং অ্যাট্রিয়াল ফ্ল্যাটার ইন হার্ট ফেলিওর এরকম একটা টাইটেল আপনি সুন্দর করে সাজায় টাইটেলটা আমাকে একটু মেসেজ করে দেন।
আচ্ছা really flutter is a big problem in heart failure. আমার মনে আছে good topics. জামিল you can work on it.
আমার একাধিক পেশেন্ট এটা আছে যে হার্ট ফেলিওরে যে ফ্লাটার দেখি এবং আমাদের দেশে এটা অ্যাবসলিউটলি আন্ডার ট্রিটেড। কেউ এটাকে কার্ডিও কনভার্সন করে না। আমি করে দিলে যে কি রোগীর যে কি বেনিফিট হয় রিমার্কেবল। আপনি আগে দেখতেছেন 34%, 3 মাস পরে ফ্লাটার কনভার্ট করে দেন দেখেন ইজেকশন ফ্র্যাকশন 64%। এইরকম এই পরিমাণ চেঞ্জ হয়, মানে না দেখলে বিশ্বাস করা যায় না।
আচ্ছা ওয়াদুদ ভাই, it is already 2.5 hours. Our next session is
we have to finish.
আচ্ছা 26th, that is next session will be 26th of this month. You please just conclude the session and finally again congratulations to Professor Abdul Kader.
Yes.
Conclude করেন।
ওই দিন কার আছে?
ওই দিন আমরা জানাবো আর কি।
আচ্ছা, খুদা হাফেজ, গুড নাইট এভরিওয়ান।
Okay, thank you, good night.
ওই দিন অ্যাকচুয়ালি হাফিজ ভাই ছিল, হাফিজ ভাই যদি না দিতে পারে তাহলে আমাদের অল্টারনেটিভ অ্যারেঞ্জমেন্ট থাকবে। থ্যাংক ইউ।
খোদা হাফেজ, আসসালামু আলাইকুম।
আল্লাহ হাফেজ।
Thank you.
থ্যাংক ইউ।